This week on the BackTable podcast.
I think some of the happiest cystectomies I do are people who have terrible urinary symptoms. And cost effectiveness wise, I suspect that if we start comparing to someone who's getting BCG, then Adstiladrin, then Anktiva, cystectomy may be more cost effective as well. That being said, I don't push it in like high-grade TA patients or low-volume CIS or anything like that. But high-grade T1, high-volume, variant histology, any prostatic involvement, anything like that, it's a discussion that we absolutely have to be having still.
Hi, everyone. Welcome back to the BackTable Urology podcast. My name is Dr. Ruchika Talwar, and I'm a urologic oncologist in Nashville, Tennessee. Today, I'm thrilled to be joined by my good friend, my partner, and actually often mentor of mine as well, Dr. Amy Luckenbaugh, who's a urologic oncologist at Vanderbilt University Medical Center. Dr. Luckenbaugh, we're thrilled to have you. Why don't you start by just giving us a quick introduction?
Thanks so much for having me. Very kind introduction, kinder than what I'd give myself. So I am a urologic oncologist at Vanderbilt, and I tend to focus a lot on bladder cancer. And so I think that's a little bit of what we're going to talk about today.
That's right. We're going to be talking a lot about coping with bladder cancer management in the era of BCG shortages. And it's really interesting. You know, I feel like this topic comes up every few years. We see shortages get worse, get exacerbated, and it's been pretty tough for us as a field to stay resilient. And, you know, I think it would make a lot of sense for us to set the stage. I know that although BCG is the standard of care for bladder cancer, I'm not sure everyone knows how we quite got here and why BCG is such a mainstay of bladder cancer treatment. So let's start there. You know, what is BCG and how did we even start using it in bladder cancer?
Great question. BCG kind of originated as a tuberculosis vaccine. And in 1976, there was the first report of using BCG as an intravesical agent for superficial bladder cancer. And that was kind of the early times that started to be talked about. I tell patients it's like a cousin to tuberculosis, so they don't get too freaked out. And in 1990, the FDA approved BCG for the treatment of non-muscle invasive bladder cancer based on years of data that shows that there's a 70% recurrence prevention and also reduced progression, very importantly. So really, it kind of came about like that. And from 1990 until fairly recently, there really wasn't much else out there.
Yeah, great point. I mean, that's exactly what I was going to ask you. It's like for decades, we were relying on something that was really discovered in the 70s. And it's like, okay, fascinating. I mean, we will get to some of the ongoing activity that we're seeing, and there's a lot of excitement in non-muscle invasive bladder cancer now. But, you know, I'm curious, you trained and you started your practice. I guess when you started, we may have been coping with shortages, but at least during training, I know you really did train in the era of reliable BCG supply. And so, you know, at that point, at least early on, how were there any challenges getting BCG to patients? I'm asking because, quite honestly, as far as I can remember, we've been talking about shortages.
Yeah, that's a great question. I really don't remember talking about shortages till late in my residency, which was 2017, 2018 was the end of my residency. Until then, I didn't really know that was even a concept. It seemed to me like if we have a drug, we can make the drug and we can give the drug, and why would there be a shortage? But since then, there's been ongoing shortages, including the beginning of when I started practice, which was during COVID. And then also even more recently, I think there's still a pretty good shortage, largely throughout the country, throughout the international community as well, not just here.
Yeah. And so what happened? What happened between the 90s when we really started establishing BCG as a standard of care up until that 2017, 2018 mark?
Yeah, I think a couple things. One, in the U.S., the only producer is Merck after people left in 2012, and Merck can't keep up with the need. Frankly, it takes about 3 months to make BCG or manufacture it. And that, if you imagine, if we're giving that weekly for 6 weeks to thousands of patients, trying to keep up with that is astronomical. And BCG isn't the only thing Merck does. So there are like substantial back orders. And now Merck is like relying largely on essentially allocation systems, like distributing it to high users and distributing less to people who use it less. I know they have a new facility that is planned supposedly that will come out in late 2026. I think I will believe that when I see it, but it would be great if that did happen because it definitely an issue.
Yeah, I've been hearing a lot about this facility too. So I, like you, am eagerly awaiting news there. And I can't help it. You know me well, and I'm a little bit of a health policy nerd. And so like I think this story is so interesting, right? Because you're right. Merck is the single supplier, but like people might ask, like, why did that happen? And I think it's really because BCG is such a low cost drug. There's not a big margin on it, and so there was less of an incentive for other manufacturers to remain open. And it just like exposes some of these real supply chain issues that we've seen, obviously in BCG over the years. But I'm thinking a lot about the gemcitabine cisplatin issue. For our bladder cancer patients, cisplatin had a shortage.
Yeah.
And we rely on, for not for this disease state, but for muscle invasive and metastatic, we rely on cisplatin. And that was like another carboplatin had a shortage because a plant shut down. And then therefore more people were using cisplatin. And then we couldn't keep up with demand because there was only one supplier. So like common themes here. And I think that it's super, super interesting. But let's talk about, not quite the anatomy of the current shortage, but like what we do in the clinic, right? Like this affects us in real time. And most importantly, I think about some of those really challenging conversations with patients, because when they Google non-muscle invasive bladder cancer and they say like, I'm supposed to be getting BCG and you're potentially not giving them BCG, I'm curious, like, how do you discuss these challenges with patients?
That's a great point. When I first started during COVID, I think was the time that I had to do this the most. I haven't had to do it recently, fortunately, but I think it's super important to make it clear, like it is not unique to you as a provider. I think that's something, especially in the community, it's not unique to them. It's happening everywhere. And to highlight that to patients that this is something that's related to production. It's not that we're withholding BCG. It's not our fault. It's not that our office isn't ordering it. And to really talk about there are great alternatives and we have alternate methods to distribute BCG. For example, focusing on people who are higher risk. We'll get into probably a bit later, I imagine, stuff about splitting doses and letting them know that stuff is okay. I think also making sure that we set those expectations ahead of time if the shortage is in existence so that they aren't surprised, documenting that we've talked to them about the shortage and alternatives as well is so important. Otherwise, most of them are pretty understanding unless they are surprised and all of a sudden they aren't getting it and can't get it and don't have an explanation as to why.
Yeah. You mentioned split dosing BCG, and I remember particularly in residency, a little less, like you said, here at Vanderbilt, but definitely in residency, we had a big shortage, and splitting our BCG dosages were a big way we dealt with that and made sure that patients were still getting adequate intravesical therapy. And so share a little more about what you all have done, what your experience has been. How do you split dose? What's the evidence behind that? Is it safe?
Yeah, there is pretty good evidence behind it in lots of guidelines, European guidelines, American Urologic Association guidelines kind of give guidance on it. There is there's some evidence from multiple institutions that there's very minimal impact on time to recurrence, time to progression, even if you are giving someone 1/3 the dose of BCG. This is something we do in patients who, for example, can't tolerate BCG at baseline. So it kind of became extrapolated from there. But in general, I would say splitting the vials of using 1/3 to 1/2 the dose, if you're able to, is a great option. And there is a lot of data to support that is out there from numerous places, including the EORTC. They really found disease-free rate was not superior for people receiving a full dose. They did find that, if you were able to give high-risk patients the full 3 years of maintenance versus 1 year of maintenance, that was better. And so some of what we do is, one, for high-risk patients, we prioritize full dose induction if we're able to do it for high-risk patients. 2, we try to prioritize giving maintenance to those high-risk patients. And for intermediate-risk patients, those are patients who may not be getting maintenance anymore. 3, splitting the dosages, as I talked about. And I know groups, and we had kind of standards here that we established. Here are the guidelines. Here's what's going to happen. Some places with smaller practices review each patient as a group and come to a consensus of who should get it. And so there are options to maintain this BCG supply. It's just not ideal.
Yeah. And you bring up a great point. It's like pathways, standardized guidelines. So like everybody's on the same page. You also articulate to the patients, here are our guidelines, there's a standard process, so they know that we're dealing with every case uniformly, and I think that helps assuage some of the patient concerns. I like that there are some resources out there. You talked about the guidelines that came out. I know the AUA had put out like a sort of like an emergency communication at the time of the shortages. Beacon had some stuff. What are some other resources community folks can look at if maybe they don't have the infrastructure for a committee?
Absolutely. So the AUA had great risk adapted guidelines that were put out that were very, very clear and made recommendations on how you could do it. And then you can cite that to patients so you aren't viewed as, oh, we're doing this to them at our own free will. It's like something that's recommended. And then, as you mentioned, the Bladder Cancer Advocacy Network has really great resources for bladder cancer. And so that's something I send patients to, and community like urologists can reference, that this is their kind of protocol as well. And this isn't unique to us necessarily. This is what's being done kind of everywhere. And if they wanted to get into the weeds, the European Association of Urology has similar things, but really there are really good guidelines out there, and they should try not to worry. The recurrence rate may be a little higher, but not a ton, and the progression rate is not impacted, and cancer-specific survival isn't impacted. So really, they should feel okay if their dose has to be reduced.
Yeah. And, I know we mentioned perhaps for certain intermediate risk patients, they're definitely, I think maintenance is off the table in a time of a shortage. But I think that's intermediate risk is an interesting space, because I think the case could be made to forgo BCG for some of those people. But I know now we also have some new options. And so I want to cover some of these new options. Let's start with intermediate, just because I think it's great to have like a true BCG alternative. Unlike some of the other high risk emerging drugs, I'm not sure those are alternatives yet. They're more like salvage options. But I think that's what makes me excited about the intermediate space. So tell me about what your thoughts are with some of our new alternatives out there.
Yeah, I totally agree about the intermediate risk patients. Even before the new exciting alternatives came out, and patients who had low-grade intermediate risk disease, at times I preferred using gemcitabine or an intravesical chemotherapy over using BCG, both in a shortage era, but sometimes the efficacy just seemed a little better. But if you could maintain the ability to not give BCG to those patients with low-grade intermediate risk disease, that would be awesome. And so there's kind of intravesical chemo agents. Mitomycin historically was used a lot with really good evidence, but a lot of side effects. And gemcitabine then kind of came out. And I tend to prefer that as intravesical chemo, solitary intravesical chemo. But what has recently been approved that is a little bit more exciting is a mitomycin hydrogel, which seems better tolerated, truthfully, than the intravesical mitomycin that I remember from my residency. And that is based on trials that looked at, it's an intermediate risk population where mitomycin gel, which is like allows it to dwell a little longer and then break down in the urine and be passed out. And that really had a great CR, a complete response rate of 79% at 3 months. I think that also is something that could be exciting.
Yeah. And I like the idea of saving BCG for when we need it, because let's not forget, for these patients, it's progression is maybe not as much of a concern as some of our other high risk patients, but it is still a concern. And so it feels good to still have BCG in our back pocket, because we'll talk about some of these new drugs, but they're pretty expensive. So it's nice to keep that option.
Completely agree. It is nice. And if they convert to high grade, they can get BCG. But if they never become high grade, gemcitabine alone or this new exciting medication in the form of mitomycin hydrogel that gets put in.
Yeah, and tons more activity in the high-risk space. Again, I want to cover this, but I want to, kind of put out the caveat that most of these agents are still for patients who have failed BCG. We're not quite ready to replace BCG. And so first, let's go there actually before we cover these agents. Tell me, what are your thoughts on that? Because there's a lot of activity happening, and I still I get really excited, but my hesitation is, well, it's still not a BCG replacement. So tell me what you're thinking when you hear about some of these new drugs.
Yeah, I think they're all exciting. It's great to have a backup to BCG, but so far, there's trials ongoing comparing things to BCG, but so far everything is for BCG refractory patients, so it isn't approved as frontline. And I think the cost of some of those drugs may prevent it from being approved as frontline if they can't prove that they are superior to BCG. And I think that's kind of on those companies to prove that they are superior to BCG so that they can be used as frontline, in my opinion.
Yeah, no, I think that makes sense. And again, even if they are approved, it's the patient is going to be carrying some of that financial toxicity, right? So it's if we have the option, great, but that still may not be the best next step for some folks.
Absolutely. Absolutely. And there are relatively cheaper options like chemo-based intravesical therapy is obviously cheaper than some of the new things, but we don't have great prospective data on that.
Yeah. So let's cover them. You tell me which one you want to start with, but I think it'd be helpful to let the audience know about some of these exciting high-grade agents too.
Yeah, I think we'll start from the cheapest. How's that?
Yeah,
we'll start
great.
with gemcitabine and docetaxel, which in some, although the data, like I said, right now is retrospective, they looked at patients who got gemcitabine docetaxel and their 1-year recurrence-free survival was 60% for high-grade non-muscle invasive bladder cancer. So relatively comparable to the data that we have for BCG. When you're looking out to 2 years, it was about 50% recurrence-free survival. And again, that was all collected retrospectively. It is ongoing, being compared to BCG directly head to head, which is awesome. I salute them for doing that comparison in the Bridge trial. And I think the results of that will be really exciting. I hope that it will show us something like that it is either equivalent or non-inferior, because there are practices who when they can't get any BCG, they're using gemcitabine docetaxel induction course as their primary treatment. And I think that's kind of the most common de facto substitute right now.
Yeah, agree. That's what I think. So I think that's accurate. I know sometimes I'll use gemcitabine docetaxel in patients who I want to get intravesical therapy, but they may be immunocompromised or
Yes.
there may be some other contraindication to BCG. So I love having that in my back pocket.
Completely agree. And it is reasonably priced relative to all the other things out there, and given in a very similar method that we're very comfortable with as urologists, weekly for 6 weeks kind of thing. It does take a little bit more time in clinic, which than BCG because of the sequential dosing. But I think overall, it's a great option as an alternative to BCG. Even if there was, if there is a shortage, is not a shortage, it can be used in BCG refractory patients, but also with shortages.
Yeah. And now there's some other drugs. What I'm really fascinated by is TAR-200. And the reason is it's not a new drug, right? So it's getting creative with a mainstay gemcitabine, which we've talked about a few times, but it kind of bridges this idea of delivery system, dwell time, the exposure to the affected mucosa, all of that. So what are your thoughts on TAR-200?
Yeah, I think your point about the dwell time is key. So BCG, gemcitabine, docetaxel, we say hold for 2 hours, 1 to 2 hours, please. And then they void it out and it's gone. And the TAR-200 really captures the idea. It's a little mini pretzel that is put in the bladder cystoscopically or with a catheter. Placement is confirmed cystoscopically, and it really it stays in for 3 weeks, and it's slowly long dose, almost like extended release form of gemcitabine is emitted into the bladder, and that was studied primarily in a BCG refractory population, but they had a really excellent response rate in the BCG refractory population. They also are doing a trial looking at in the BCG naive population in Sunrise 3, comparing it to BCG, which I think also will be interesting. Again, it's given via a little catheter that's put in, and that thing floats around your bladder and it prolongs the dwell time. And I think their thought is, well, if the dwell time is longer, will the outcomes be a little better? We don't know that answer yet, but we do know it works well in a BCG refractory population. And I believe they submitted to the FDA, and where we're waiting to hear approval for the BCG refractory folks.
Yeah, and I think eventually if they can prove either superiority or non-inferiority to BCG, the interest in the naive population, I think the interesting thing will be avoiding that weekly clinic visit potentially.
Yes.
And like for patients who, again, there's a shortage, right? So some of these people have to drive like 4 to 6 hours, especially for us and being in Nashville and having a lot of rural areas around us. I think that'll be a nice option for folks.
Completely agree. The dosing convenience will be great.
Yeah. And then there's some like really exciting scientific advances in terms of, oncolytic therapies, immunotherapies. So tell me your thoughts on all of those agents.
Yeah. To talk about delaying or prolonging the time needed between doses, I think I'm talking about Adstiladrin. So that is a medication that is, again, approved in the BCG refractory setting where it's given by a catheter, but it's given once every 3 months. And so the response rate for patients who had BCG refractory disease, it was pretty good at any time. It was about a 50% response rate. In patients with high-grade TA, that sustained response was pretty good also. And the convenience of the dosing of that is huge, especially like you said, in the time of a shortage. We have patients coming from like 5 hours away weekly to get BCG. So being able to dose something once every 3 months is impactful, not only for their convenience, but also for work, for everything like that, travel costs, all of that. And so that isn't approved in the BCG naive setting, but it is definitely a great tool in the BCG refractory setting.
Yeah. And then we have Anktiva, which it's always funny to talk about Anktiva when we're addressing BCG shortages.
Yes.
Right?
Yes.
And so let's tell our audience why.
So Anktiva is a medication that it's an IL-15 with BCG. So BCG is required for Anktiva. That being said, it again in the BCG refractory population has really outstanding results. It's given very similarly to BCG. So again, something urologists are very comfortable administering weekly for 6 weeks with maintenance courses. But I think that the one quote unquote downside to this is that it needs BCG and potentially dosing frequency is too. But their complete response rate, it's pretty high, higher than a lot of the ones at 12 months. It's a sustained complete response rate of like 45%. So the data to support it's very good medication. But the BCG, the fact that it needs BCG, the fact that the travel, you may still have to come weekly for 6 weeks, may turn some people off of that.
Yeah. And there are more drugs. So this is by no means a comprehensive list. There's lots of trials ongoing. We have Credo, we have other options. But I want to talk a little bit about, instead of more intravesical options, let's not forget about cystectomy, right? Because sometimes I think we're not as keen to offer that in either a BCG failure setting or even sometimes as an alternative. I think it's not unreasonable, though, in some patients who truly have very high-risk disease.
Yeah. I think we all are so excited about the new space and the possibility of prolonging patients' ability to not need a cystectomy. That being said, there are some patients that we really shouldn't forget about it. Those patients with like high volume, high grade T1, variant histology, things like that. We really shouldn't omit the discussion about early cystectomy, especially also some of these people, if they have terrible bladder symptoms and can't hold the medications and can't get the medications and have bad cancer. Those are people that early cystectomy may be what it suits them best. It has excellent cancer-specific survival for non-muscle invasive disease. If they're symptomatic from their bladder, it can rid them of that. I think some of the happiest cystectomies I do are people who have terrible urinary symptoms. And cost effectiveness wise, I suspect that if we start comparing to someone who's getting BCG, then Adstiladrin, then Anktiva, cystectomy may be more cost effective as well. That being said, I don't push it in like high-grade TA patients or low-volume CIS or anything like that. But high-grade T1, high-volume, variant histology, any prostatic involvement, anything like that, it's a discussion that we absolutely have to be having still.
Yeah, and that reminds me of the data that was presented that John Gore and Angie Smith have really been championing, looking at quality of life in patients. And I think some of the quality of life improvements with radical cystectomy stem from what you just talked about. It's really the fact that a lot of these patients have underlying lower urinary tract symptoms. And I think when we are thinking about, oh, well, you get to keep your bladder, you get to avoid a major surgery, that has not an insignificant complication rate, we forget that there's a lot outside the immediate perioperative period that the patients are still struggling with.
Absolutely. Yeah, completely. And I think if you talk to the people who are administering the intravesical therapies in clinic and all the strategies they have to use to get people to hold them, there are some people that really would probably be better suited with a cystectomy at some point, whether upfront or whether after one round of therapy or two, they may be just headed that direction.
Yeah. So we covered a lot of BCG alternatives. What regimens, number one, have you adopted the most? And I know you've talked about gemcitabine, docetaxel, so we've already covered that. But beyond, maybe in the high-risk space, what have you adopted? What convinced you? And what excites you?
Yeah, it's a good question. I think so far, and we have Adstiladrin and Anktiva both available to us at Vanderbilt. We also have pembrolizumab, which we didn't talk about. I tend to not favor pembrolizumab just based on the systemic side effects that are given, and the long-term CR rate at a year just doesn't excite me quite as much. That being said, I would say, like you said, I use gemcitabine, docetaxel not infrequently. And then I talk to patients about both Anktiva and Adstiladrin, and I tell them the data behind both. And honestly, a lot of patients are choosing the Adstiladrin because my personal population are people who are from far away. And so the convenience of the dosing for them is huge. I think that, in all honesty, is probably the most exciting, is the convenience of dosing. If you really talk to patients and the impact on their life, that would be what excites me the most. I think seeing what the rest of the trials come out with, Credo, so many ongoing, I want to see what Bridge shows, because I agree with you. In immunosuppressed patients, I'm doing gemdosi anyway. There's just so much out there right now that's ongoing, and I'm excited to see where everything goes.
Yeah, I know. You're right. We didn't cover Pembro, and I know there's other systemic agents, either with or without intravesical therapy, that have also been presented at some of our big conferences. So again, just super saturated space. We'd probably have to do 3 of these if we wanted to cover all of them.
Absolutely.
But, I'm really looking forward to the future. I think I'll mention this is going to be a really important time for societies to really step up and give us all guidance, because there's going to be a lot of options and people are going to be adopting different preferences, again, based on whether it's dosing, whether it's cost, whether it's access. And so, what do you think we should be thinking about? You are one of the leading experts in the field. I know you sit on some of these guideline panels. What questions are you asking yourself and your fellow guideline panel members when you're trying to figure out what the algorithm's going to look like?
Yeah, that's a super complex question. I think it's a great question. Obviously, I think one of the biggest things that not just the guidelines people are going to be asking, but probably the FDA is going to be asking, is how does it compare to BCG? And so anybody who is able to do those comparisons may be a little ahead of the game in getting approval, in my guess. I think that's one of the things that will be important. I think then from there, I think of it almost like the NCCN guidelines with the thousands of preferred regimens for metastatic disease and bladder cancer, for example, or other cancers. We need to come up with here's the preferred one and here are the alternatives. And that's, I think, will be important. I think that we probably should also now that we're getting into a space where the cost is exorbitant, have someone financially take into account cost. I think that should be taken into account as we go forward with this. As well as, and the last thing is as the kind of side effects and how well each thing is tolerated, I think should play a role for sure. And that's where, when I think about that, I think about like systemic side effects versus just local side effects and things like that. So all of that should become part of what we think about and what we talk about. But I think if you omit like patient quality of life outcomes with regards to this that include costs, then we're doing a pretty big disservice to patients.
Yeah, I couldn't agree more. I mean, the quality of life in this disease state at baseline is such a complex area. So totally agree with you. And I'm really encouraged that a lot of the trials that we see in this space do include some of those considerations. So it does help. It definitely helps. I think the thing I struggle with too, and I tell my patients, is it's like, I can't predict how you're going to react. And that's the most challenging part. And just letting patients know that here's the data, but in reality, especially when it comes to the quality of life side effects, like it can be so variable.
It's completely variable. Some patients with no complaints at all, some patients with tons of complaints and urinary issues and some patients don't tolerate BCG, tolerate chemo. You have no idea who they are going to be and why.
Yeah. Well, I think the whole story here and thinking about BCG, where we came from, where we are today, what we're still struggling with in terms of shortages, really underscores this idea of innovation sometimes being the simple things outside of like these really exciting drugs. I think scarcity demanded creativity and not compromise here. And it was really interesting to see people extrapolate data about like split dosing and ways to share and all of that. And so what are your biggest takeaways from, the BCG shortages, and what do you want folks, especially out in the community, to keep in mind as they struggle with this ongoing problem?
Yeah, I think my biggest takeaways are, one, like there's very little downside to split dosing. If you have to do it, do it. Two, prioritize those high-risk patients primarily, and potentially, as you said earlier, not give maintenance in intermediate risk patients. Patients with low-grade disease, intermediate risk, low-grade disease, try not to give BCG, try to save it, try to spare people, give them gemcitabine or the new mitomycin hydrogel, do something like that. Don't waste BCG, quote unquote, on those patients. Save it for when they have high grade, high risk disease. And then I think the last thing is we can't depend on a single supplier that for something this complex. I mean, even you think about like saline, there were saline shortages, right? Which is insane. How is there a saline shortage? And so trying to figure out the supply chain aspect of things is super important. But as clinicians, we may not have the role to do that. You may, Dr. Talwar, and everything you do. but I think trying to prioritize the patients who are most appropriate for BCG.
Yeah. No, I mean, I agree with everything you said. And in terms of the shortages, I think this is just another lesson in addition to, like you said, saline, platinum shortages, redundancy in medication and pharmaceutical supply chain is not waste, it's resilience, right? And it's like so important. So I hope we can all continue to have our voices heard when we struggle with these things, and hopefully through, episodes like this, we can at least help standardize across the country and across the world the way we cope with some of these really frustrating ongoing shortages.
Yeah, I completely agree.
Awesome. Well, Dr. Luckenbaugh, thanks so much for sharing your expertise. Again, I have the privilege of working with you, day to day, and I'm super excited that everyone else gets to hear some of your pearls of wisdom, because I know you are such an expert here. I know your patients really appreciate the thoughtfulness of the care you provide. So I'm glad to be able to share some of that with our BackTable audience.
Thanks so much for having me. I appreciate it.
Thanks to our audience for tuning in. We'll see you next time. Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio.
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.